of the ACCHA staging and the NYAHA functional classification and how they kind of tie in to each other. But let's start with stage A, ACCHA stage A heart failure and how to treat it. Okay. So somebody qualifies as stage A if they have a condition that puts them at risk for heart failure. They're at risk, but they do not have any symptoms, and they've never had symptoms, and they don't have any structural or functional cardiac findings on echo. So this would be patients who have hypertension, people who've had cardiovascular disease, people who have diabetes, even patients who have obesity would fall under this stage A or at risk for heart failure. And when you look at the treatment recommendations for it, according to the algorithm, it's basically let's manage these risk factors so that you don't have continued clinical decline so that they progress from stage A at risk to now stage B or stage C or even stage D. So how can we manage these risk factors appropriately to prevent that progression? So if they have hypertension, let's optimally control blood pressure. It doesn't have a specific recommendation what that medication is, but just manage it, meet goal, and such.
The patients that are in stage A with CVD, diabetes, or anything like that, will they become managed on medication or and then go back to normal BMI because they become out of stage A, or they still in stage A once they have one of those things?
The obesity, I could see them downgrading, but hypertension, they're always going to have that, or at least have the propensity to it. If like diabetes as well, like they're always going to have the propensity, even if they have like a drastic weight loss and now they're technically not diabetic, because they had that condition, they have a propensity for going on and developing it. So most cases, I would still say they're stage A, even if they eliminate those conditions. Yeah. Part of it is also like how long did they have those conditions? Was damage already done because of that condition as well? So there's a lot of kind of factors that go into that. But yeah, so for hypertension, there is no specific recommendation for the blood pressure medication to use. If you have a patient who has diabetes, then they recommend doing an SGLT2 inhibitor. And I will tell you, based on new literature, new research, you can also add GLP-1s to this as well. So anytime you see SGLT2, just put a slash and put GLP-1 as well, okay? Because as the science is coming out with GLPs, we are finding that the benefits of SGLT2, cardiac mortality reduction, all that kind of stuff, we're finding that with GLP-1s as well. So, but these guidelines were printed out or done in 2022. So GLPs really were pretty fresh to the market. So we didn't have some of those long-term data to support recommending them at this level. So, but yeah. Patients with cardiovascular disease, coronary vascular disease, let's optimally manage that. Okay, whether that be with medications like with stable angina, or do they need a stent to restore perfusion to a at-risk area. Patients with exposure to cardiotoxic agents, so this would be like your chemotherapies, your radiation, those types of things that can harm or damage the heart, then let's send them to a team that can kind of watch them carefully to make sure that one, they're maybe not getting exposed to these substances anymore, or we can limit their exposure. So if it's like a patient undergoing radiation therapy for prostate cancer, can we shield the heart and protect them from being exposed to radiation? Those kinds of things. And then genetic screening for maybe genetic conditions that might put them at risk for developing heart failure in the future. And if we can identify those who have genetic propensity towards this, what can we do to counter that? Now, stage B is somebody who has never had symptoms, and doesn't have symptoms, so no symptoms, but they have evidence of either a structural heart disease, which includes reduced left or right ventricular systolic function. It includes ventricular hypertrophy. It includes wall motion abnormalities. It includes like valvular heart disease. So there's something structurally wrong with the heart there. That would be a stage B. They could also have evidence of increased filling pressures. So either we do a catheterization procedure and we can measure that those elevated pressures, or maybe some other cardiac imaging shows that there are elevated pressures within the chambers of the heart. And then patients with risk factors, and they have an increased level of the BNPs. So remember, we said that BNPs are only really secreted due to atrial or ventricular stretch, depending on which one you're testing for. So if there is that stretch present, that's telling you that the function of the heart's not really working as well, and that's going to cause the release of those things. So if you're detecting these, then that shows you that the heart is under some kind of stress. So if any one of those criteria is present, and they're asymptomatic and never had symptoms related to heart failure, they fall under the stage B category. And when we look at the treatment now for stage B patients, you can see we now are recommending specific medications to address these things. So, for instance, patients who have that left ventricular ejection fraction of less than or equal to 40%, so they meet that true definition of HFrEF, they should be on an ACE inhibitor. If they can't tolerate that ACE, let's put them on an ARB. Let's put them on a beta blocker. And then if they have a left ventricular ejection fraction that's less than or equal to 30%, they have a greater than 1 year survival, then we're putting in an implantable cardiac defibrillator. So we're going to put something that's going to shock the heart if they were to develop an arrhythmia. Okay. So why is it that these medications specifically are recommended in this stage, and why is it in heart failure? Okay. So from an ACE inhibitor and an ARB standpoint, we know how they work. I'm not going to revisit that. But the reason that this specifically is recommended is because when we did studies of using these agents in patients with HFrEF, especially stage B HFrEF, we actually found a mortality benefit with it. And not only a mortality benefit, but also a reduced hospitalization rate with the use of this medication. And it's because one of the secondary effects of this is it reduces that adverse remodeling. So you preserve the myocardial cells that actually are functioning, and you limit the scar tissue formation from that stress that the heart's under, and you limit that from affecting the healthy myocardium itself. So there's a mortality benefit with ACEs and ARBs. Beta blockers. So we've talked about the mortality benefit from a cardiac standpoint. It limits the adverse remodeling. And we highly recommend using these in the asymptomatic patients, or patients who are not in that acute decompensated state because of that mortality benefit associated with them. It is contraindicated, though, if they are presenting to you in that acute decompensated state. You do not start beta blockers at that moment, because if they're already in that acute decompensated state, they have that reduced cardiac output. By putting them on that beta blocker at that moment, I'm only going to make that cardiac output worse, because I'm decreasing my heart rate and I'm decreasing my contractility. So I'm only going to make that cardiac output, that decreased cardiac output worse. So in that acute decompensated state, don't start beta blockers.
What if they're already taking beta blockers? Would you stop beta
So
blockers?
that is a recommendation that we don't really agree on. Some will say absolutely stop it right at that moment. Others will be like continue their dose, and then we'll work on the diuretics and stuff like that, because they already came in with that reduced cardiac output load. What are the chances that by taking them off, it's going to improve it enough so they're not in that acute decompensated state? So there is a contentious thing for that. This is where the cardiologist really comes in.
Okay.
But from a primary care provider standpoint, this is not their two days post hospitalization for heart failure exacerbation, and then you're starting beta blockers kind of thing. So, but yeah. So in that case, it's a little
bit curious, like in the ER setting, like it's like okay, they're presenting with acute heart failure. It's like okay, what meds are they taking? Should we remove certain?
At that point, I would consult your cardiologist and see what their thoughts are on that. Because you have some studies that show some benefit, and you see some studies that don't really show any benefit by taking off that beta blocker in that setting.
Okay.
Yeah. Any other questions? So beta blockers have a cardiac mortality benefit, and it's because it reduces that adverse cardiac remodeling. So it's not necessarily the benefit comes from reducing the cardiac output. The benefit comes from the long-term chronic thing. If you remember, we don't typically recommend first-line calcium channel blockers because even though they do the same thing from the contractility and the cardiac output as the beta blockers do, studies have not shown a mortality benefit associated with that class because it doesn't do anything to reduce that adverse remodeling. And in fact, we're going to talk about in a couple of slides, calcium channel blockers are absolutely contraindicated in heart failure patients. So, okay. So now let's say your patient has progressed. They had that structural or that functional disease, cardiac disease present, but they weren't having symptoms. But now they start to have symptoms. Now they have progressed to stage C. And once they have had symptoms, even if you throw all the medications at them and now they stop having symptoms, they will never downgrade to stage B. They will always stay at least at stage C, ACC, AHA. And we're going to kind of talk about stage C and D together because the algorithm, the HA-ACC put together, actually has these two stages together on the one page. So we'll walk through this algorithm now on how we manage this patient. So step one is first to confirm that they actually have stage C. So they have that EF less than or equal to 40% and symptoms. Okay, so they qualify for a stage C. The goal-directed medical therapy for this patient is we're going to start an ARNI. And ARNIs are, when you look in the recommendations, you look at some of the supplemental studies that have come out, we would prefer every patient with heart failure, stage C was, to be on an ARNI versus just the ACE or just an ARB. Okay, so to truly hit this goal-directed medical therapy, let's say they were stage B and we had them on that ACE inhibitor and now they're having symptoms, so now they're stage C. Do you continue that just ACE inhibitor or do you stop that and put them on the ARNI? And the literature says put them on the ARNI if they can tolerate it. Okay, so we're going to put the ARNI on. If they're not already on a beta blocker and they're not in that acute decompensated state, let's put them on that beta blocker. Let's put them on a mineralocorticoid receptor antagonist, and let's do an SGLT2 inhibitor / GLP-1, even if they don't have diabetes. This is one caveat. In stage A, we said diabetics should be on SGLT2s. But in stage C, even non-diabetics benefit from an SGLT2 or a GLP-1. And then we think diuretics typically are our mainstay for treatment, right? But what does it say? Diuretics as needed. So diuretics may not be a daily medication that they take. It may be only when they have fluid overload present. So why is it that we recommend an ARNI over an ACE or over an ARB by itself? Well, one, it's a combination of valsartan, so it's a ARB, right, and sacubitril. I'm not going to talk about valsartan because we've already talked about the advantages of ACEs and ARBs. But the sacubitril is a neprilysin inhibitor. Well, what does neprilysin do? Neprilysin is secreted, and it breaks down natriuretic peptides like BMP, proBNP, and deactivates them. But remember, we said in a heart failure patient, the only neurohormonal response that actually has a clue what is going on and actually provides a positive benefit is those natriuretic peptides, right? It reduces the RAS activation. It reduces the renin being hypersecreted. It causes a vasodilation. It causes kind of like a diuresis because you get vasopressin being, or the antidiuretic hormone being blocked. It's the only thing that actually has a clue what's going on and actually has a positive benefit. So if I block neprilysin from degrading these natriuretic peptides, I only then have higher levels of these circulating and actually working and actually giving a positive benefit. Okay? So that is why an ARNI is highly recommended over just an ACE or just an ARB by itself. But then you get the valsartan ARB component to it, so you get all those positive benefits, the mortality benefit of being on that as well. So that's the great thing about having this combined medication. Mineralocorticoid receptor antagonists. From a hypertension standpoint, we talked about how this is not a primary or first-line agent to manage hypertension. We said it's more of an adjunctive type of therapy. But in heart failure, we do recommend mineralocorticoid receptor antagonists because, again, when we look at the effects of it, we inhibit cardiac remodeling, so that adverse cardiac remodeling that occurs. So we're limiting that. And then ultimately, it gives us a mortality benefit and a reduced hospitalization benefit. So you can see ACEs and ARBs, mortality benefit, beta blockers, mortality benefit, mineralocorticoid receptor antagonists, mortality benefit. So you're seeing there's reasons we do this. And if you see a common trend, all of those things that have that mortality benefit, it inhibits that adverse cardiac remodeling. But be careful, because if you have that ACE and the ARB, what's happening to the potassium levels already from ACEs and ARBs? And now you have this aldosterone antagonist also. You have to watch that potassium very carefully. Because potassium hyperkalemia, we'll talk about it especially in block 4, can be very pro-arrhythmic. So you're going to have a lot of arrhythmias developing if that potassium level gets up too high. And oh, by the way, what's the chances of somebody with heart failure having kidney disease and not really being able to get rid of potassium well? So be careful. SGLT2 inhibitors. Why do we recommend it? Reduced cardiovascular risk, MI, stroke, or even death. So again, a mortality benefit from SGLT2s. Diuretics. They're fluid overload. They got all this extra fluid in their lungs. They got all this peripheral edema. you would think that this would be the best agent to treat them. And in the short term, yes, because it helps with the symptoms that they're experiencing. However, when I look at the risk of death, and all I have them on is a diuretic, long term, no benefit on mortality. So I can treat the symptoms, but I'm not treating the adverse cardiac remodeling that's occurring. So I'm not doing anything to preserve cardiac function that I actually do have. So this would be somebody who, like, you know, has an EF at 35. Well, in 6 months now it's 34, 33, 32. It just continues to drop because you're having all those adverse remodeling occurring, which is impacting that actual function of the myocardial cells that are there. So we did step 1 on the stage C ACC-AHA guidelines, goal-directed medical therapy guidelines. We optimized all of those medication dosages. So we either had to titrate them up slowly or down titrate because they weren't tolerating, whatever. But we get them on the optimized dosing. Then we have to come back and see, did it work? So let's repeat our echo on step 2. Let's repeat our echo, and let's see what our EF is now. If it is now greater than 40, great. Our treatments had a positive benefit. Let's continue those medications at that optimal dose, and let's watch them. Let's make sure that they don't continue to clinically deteriorate over time. Okay. But if I do that echo, and now my EF is still less than or equal to 40, maybe there was a little benefit. I went from 35 to now 39. Okay, there is some clinical benefit, but I'm still less than that 40. Then this is considered persistent HFrEF. And then I got to go to step 3, which is there's 3 specific patient populations where I may need to do an additional step to manage them appropriately. The first one is if your patient is African American, then it is recommended to put them on a hydral nitrate. Bidil is kind of the most common one. If it is somebody whose EF is less than or equal to 35%, then they should get a implantable cardiac defibrillator, an ICD, placed. And the reason for this is that these folks, if their EF is less than 35, are at high risk of developing arrhythmias. And imagine a stressed, limited functional heart as it is. Let me add that arrhythmia to it. What's that going to do to my function? It's going to start to affect my preload and my contractility and my stroke volume, which ultimately is going to affect my cardiac output even worse. So let's get the ICD in place. When the arrhythmia develops, it will shock the heart and hopefully reset to a normal rhythm. But if I do my echo and it shows that they have an EF less than or equal to 35, but my EKG shows that they have a left bundle branch block with a prolonged QRS, I actually have to go one step further. Not only do I need that implantable cardiac defibrillator, but I also need a pacemaker. So that's that cardio resynchronization therapies defibrillator. So CRT-D. So it's just pacemaker plus the defibrillator in place. And we'll talk about why that's recommended. But going back, so for our African American patients, the hydral nitrate is recommended because in this demographic, it actually has been shown to reduce morbidity and mortality. And the way it works is, okay, the nitrates we know are vasodilatory, right? It is effective in reducing the preload because now my peripheral venous system is going to be able to handle a lot more volume without overtaxing the heart. And then the hydralazine component to this is an arterial vasodilator. So now I'm going to reduce my afterload. So that's going to improve my cardiac output. So I reduce that excessive preload, and I reduce that afterload. That will lead to an improved cardiac output. The implantable cardioverter defibrillator is literally all it is it will just shock, it will sense the arrhythmia, and then it will shock it back into a normal rhythm. But with the cardiac resynchronization therapy plus defibrillator, if I have like a left bundle branch block, what ends up happening is right ventricle will squeeze first, and then there's a delay in that left ventricle squeezing, right? So now I'm starting to kind of lose this coordination of left and right working together to circulate blood well. So I'm going to get the right side squeezing, but then blood's going to be kind of stuck there, right? Because the basically think of a systole is delayed on the left compared to the right. So now I start to even get worsening of my preload, and my cardiac output is dropping because I'm not coordinating those efforts. So by doing a pacemaker, I can restore that coordination of left and right working together, because they're going to get shocked, or that action potential stimulation from the pacing component of this thing will re-coordinate the left and right to work together. So once we have identified those three special populations and we've done those things, then we're going to come back and see what happens. If their symptoms have improved, great. We'll continue all these medications. We'll continue to watch them and monitor them carefully to make sure that they don't deteriorate. We got to make sure that they remain compliant with their medications, so they don't have that acute decompensation occur. But let's say that they still are having symptoms, their EF is still not necessarily improving despite all of these therapies. This then leads us, we've given them everything we can offer them, but they're not getting better. So now we have teetered over the edge, and now we are stage D, or refractory heart failure. And when you look at what we do for refractory heart failure, you can see we're basically last-ditch effort at this point. Because the recommendation to treat somebody with persistent symptoms despite goal-directed medical therapy is, let's do mechanical circulatory support devices. So your left ventricular assist devices, your LVADs. There's a lot, and I'll show you on the next slide, a couple of different options of mechanical circulatory supports to help improve that pump. Maybe they just need to get a heart transplant. So remember our patient, the local San Antonian who had those heart valves, she ultimately needed a heart transplant because the function of her heart just was continuing to deteriorate. And so she needed that heart transplant. Granted, heart transplant's not something you're going to get within a month of being placed on the transplant list. This is going to be like years of waiting to get this. And then palliative care / hospice. So maybe we need to start to support the patient and their family for end of life, because we have exhausted everything we can do except for these very invasive things. We've exhausted everything we can do to make it better. This is a couple of examples of mechanical circulatory supports. So, you know, here you are wearing battery satchels and all this kind of stuff that are literally the lifeblood of this pump that's keeping this patient alive. Here's like an LVAD, or sorry, I think the LVAD's over here. Okay. But you can see there's a lot of different kind of things that we could use in this. Other things that we need to think about to optimally manage our patients are to decrease the chances of preventable infections and the risks and stresses that those place on the heart. So things like annual flu vaccine, let's prevent them from getting influenza. Pneumococcal vaccine. So we just had a former vice president die on Monday. Dick Cheney just died. Extensive cardiac history. He had pneumonia and developed complications related to pneumonia, which I imagine caused cardiac arrest. With his history and the pneumonia, probably caused that, which is ultimately what killed him. Let's monitor thyroid disease, because if you have hypothyroidism, one of the symptoms of hypothyroidism is peripheral edema, right? Well, is that peripheral edema from hypothyroidism, or is that peripheral edema from heart failure? We don't know. So test the thyroid to make sure that they don't have hypothyroidism, because that's something that we can easily manage or add to our treatment to better manage these patients. And then you've got to screen for depression. So what are depressed patients going to do? They're not going to listen to you, their treatment guideline, or treatment recommendations, so they're going to go and consume excessive amounts of salt, because food gives us happiness, right? Thanksgiving gives us happiness, and guess what? They can't eat the stuffing or the dressing, if that's what you call it. They can't have the gravy, they can't have those high sodium things, and that's pretty depressing when you see all of your family eating those things, right? Those give us happiness in somebody who is depressed. They also stop taking their medications. What's going to happen if they stop their meds? They will acutely decompensate and end up in the hospital, which then could lead to death. So screen for depression and treat it. The other thing is anybody with a chronic medical condition is going to be at an increased risk of depression. So this is a very life-affecting, life-altering chronic medical condition. So these folks are at a much higher risk of depression. And you already have higher rates of depression in the elderly as it is. So screen for this and manage it, treat it if it's there. Other things, NSAIDs, absolutely contraindicated in patients with heart failure because of the renal impairment. So even just a small dose of Motrin can affect the renal function. If I'm already teetering on the edge with fluid overload, and now I don't have my kidneys functioning properly and filtering out all that extra fluid like it should, just taking in Motrin, taking in naproxen can cause them to teeter over and become fluid overload. And then avoid calcium channel blockers for the reasons we talked about, where yes, you get the reduced cardiac output from reducing heart rate, reducing contractility, but you don't get the added benefit, the mortality benefit of these medications like you do with beta blockers. We'll start HFpEF, and actually, to be honest, we'll probably finish HFpEF before the 50-minute mark. So preserved ejection fraction. So that was all reduced ejection fraction. What are we going to do with our patients who have that preserved ejection fraction? And remember, preserved ejection fraction is that diastolic dysfunction due to filling issues, i.e. left ventricular hypertrophy. We'll talk about some cardiomyopathies that cause diastolic dysfunction tomorrow. But these are your patients who are at risk of HFpEF. And there's not a whole lot of good evidence on how to treat these patients and have a positive benefit. And there's probably a couple of reasons for this. One, this has a lower incidence or lower prevalence than HFrEF does. But two, we probably also have, because of that, we haven't necessarily invested the research dollars on patients with HFpEF. So there's just not a great body of literature that shows good treatments versus poor treatments. We're starting to fund research and getting some data now, but it's definitely lagging compared to HFrEF patients. So really, our treatments come down to, let's treat the fluid overload if it's present with diuretics, and let's manage the risk factors. So if it's hypertension, let's manage those hypertension so that doesn't cause like that acute decompensation. But this is HFpEF recommendation. So the only thing that actually has good evidence is diuretics as needed. So they have evidence of fluid overload, then they take diuretics. SGLT2 inhibitors / GLP-1s, that body of evidence is starting to get better. Even now, ARNIs, they're starting to show some good findings of good treatment outcomes. So when it comes time to change these treatment algorithms, I suspect we'll see some more green on the HFpEF management algorithm. But evidence is lacking. But despite whether or not your patient has HFrEF or HFpEF, one of the worst prognostic factors is hospitalization. If they are hospitalized, the chances of them dying goes up in the next couple of years, goes significantly higher. Typically, what's going to tend to kill your patients is that sudden or development of an arrhythmia that either is life-threatening in and of itself, or it causes such a acute decompensation of that cardiac function that it can't sustain life. So that's why those ICDs or that CRT-D therapy is there, because we want to address that arrhythmia that may just suddenly develop out of the blue and keep the patient from dying from that arrhythmia. Okay, let's take 10 minutes and we'll come back and finish up. HFrEF and HFpEF treatments. But let's now start talking about what happens when our patient's heart failure acutely decompensates and now they're coming in with profound symptoms. Well, first of all, how are they going to determine that they're having abnormal symptoms or not their usual symptoms? This is something that they're going to have to do. You're going to ask them as a provider to do on a daily basis, where they've got to do, they wake up, they have to do an assessment on themselves to see what their status truly is for that day. Which they're going to know, my normal symptoms are this. My normal weight is this. And they're going to do this little questionnaire. If they can say, I have no new or worsening shortness of breath, that my physical activity is normal, my weight hasn't changed, I don't have any new swelling, and I don't have chest pain, I am good. Okay. I can go about my day, still take the medications that are required for my HFpEF or HFrEF treatment, whatever, but I don't need any additional help. But let's say they do that assessment and they notice now they have a dry hacking cough, they have worsening shortness of breath with activity, they have increased swelling. Now they step on the scale and then they've now gained either 2 to 3 pounds in a day or 5 pounds in a week. They have discomfort or swelling in the abdomen, so that kind of that edema, that gut edema. Or they're having trouble sleeping where they can't lay flat anymore. They've got to sleep with extra pillows under their head to be able to breathe normally. Then these are warning signs of impending decompensation. And they need to reach out to you or your office to get clarification on what they do next. And it could be all they have to do is just take an additional dose of their diuretic to help get rid of that extra fluid. You're trying to keep them from coming to the emergency room and getting hospitalized by intervening early before you get to the point of no return where they absolutely have to come in to the hospital. But let's say they do that assessment, and now they notice they're having a frequent dry acting cough, they have shortness of breath at rest, they have increased discomfort or swelling, they have a sudden weight gain like we talked about for the other side, they have this new worsening dizziness, confusion, sadness, or depression, so kind of showing you poor cardiac output, poor coronary perfusion. Loss of appetite, because now that edema is just so bad, they don't have an appetite anymore. And now they can definitely not lay flat, and they're having trouble sleeping. These are red flags that they need to come to the emergency room immediately to get evaluated, to get admitted, and to get treatment for their acute decompensation. And this is, again, like we showed yesterday, the typical appearance of a patient with that acute decompensation. And we talked about how there's lots of things that can cause this acute decomposition or deterioration from their normal to that to this picture, and it includes things like, okay, their hypertension suddenly becomes uncontrolled, and now they have that increased afterload, which affects your cardiac output. They stop taking their medications. They have an infection. They have pneumonia. So lots of different things can cause that acute decompensation to occur in your patient who is already susceptible of having this happen. So what are they going to do? First steps you're going to do when you see them in the emergency room, hopefully they're going to the emergency room, not your primary care clinic, is palming. So you're going to position them upright. Let's get gravity working for us to bring that fluid down to the bases of the lungs so I can recruit all these extra alveoli to actually exchange oxygen like they're supposed to instead of being filled with fluid. So let's get gravity working with us. Let's put oxygen on them if their O2 stats are less than 95%. Let's monitor them. So primary survey, let's get some labs, let's include cardiac troponins, let's include our BNP, pro-BNP, so we can give you that definitive diagnosis that this is heart failure. And then we're going to need intravenous access. And the reason you need intravenous access is not for you to give intravenous fluids. They're already fluid overloaded, right? It's so you can give them the medications to treat the problem. For instance, don't think you learned this in pharm. When I have gut edema, I don't absorb medications correctly, especially furosemide. So I need to give them this diuretic to get rid of all this extra volume, but I now have all this gut edema that's preventing the absorption of my diuretic, so I can be throwing pills at them. They're not going to respond because it's not getting absorbed. It's not going to have an impact to increase that diuresis. So I've got to give them IV furosemide, or IV Lasix, because it won't get absorbed into the bloodstream otherwise. The other thing about furosemide is there is a 20 milligrams of PO furosemide does not equal 20 milligrams of IV furosemide. It's actually cut in half. So really, you need half the dose of IV to equal oral. So basically, to have the same kind of effect, I need 20 milligrams of PO furosemide, but to have that exact same effect with IV, I need 10. So now you're kind of thinking about the exchange and all this kind of stuff when you dose a furosemide from PO to IV. When you have a patient coming in with acute decompensation, there's one of 4 ways they're going to present to you. And depending how they fall on this kind of, in which quadrant, it's going to determine what medications you need to give them to correct the problem, okay? So we have to ask ourselves 2 questions. Well, yeah, there's 2 questions, right? So are they wet or dry? So what is their volume stats? Do they have fluid overload, evidence of fluid overload, or not? Are they warm or are they cold? So what is their perfusion? Basically, you're asking, is that cardiac output at a level that I can deliver blood, I can deliver oxygen to all my vital organs and structures. Because if it's a cardiac output problem, then I'm going to treat them one way. If it's a volume overload problem, so I'm having like an excessive preload, then I'm going to treat them another way. Or if I have a mixture of both, then I'm going to be even more aggressive. And you can see what typical treatments we're going to give depending on their presentation. So if I have somebody who's warm and wet, meaning that the cardiac output is okay to meet the minimum demands, but I am fluid overloaded, I have that excessive preload, I have congestion, pulmonary congestion, peripheral edema, anything like that, then my treatments are going to be diuretics to get rid of it, and vasodilators to try to improve my preload, my excessive preload, but also to reduce my afterload to improve my cardiac output, so I have more of a forward flow. If we have a cold and dry appearance, so I'm not perfusing, but I'm not necessarily fluid overloaded yet, I need to improve my cardiac output. So the way I'm going to do that is I'm going to give ionotropes to make sure that my contractility is stronger. So now I'm going to improve my cardiac output, hopefully in a way that I can get my systolic greater than 90, so I can at least get perfusion of the vital organs again. And then you're also going to do vasodilators for the same reason you did on the other side as far as reducing that afterload and improving that cardiac output. Now, if I'm a mixture of congested and, if I have a mixture of poor perfusion and congestion, that fluid overload, then I'm going to mix both of those treatments together, and I'm going to be giving them diuretics to deal with the fluid overload. I'm going to give them ionotropes to improve that contractility, and then I'm going to give them vasodilators. But you've got to be careful with the vasodilators, because if my systolic is less than 90 as it is, and then I give them a vasodilator, what's going to happen to that systolic?
Drop.
It's going to drop even more. So I got to it's kind of a Goldilocks thing. A little bit here, a little bit here, trying to get this corrected. Let's maybe give the ionotropes, get my systolic higher than 90, so I can start to get a whiff of the vasodilators without dropping the systolic less than 90. So you can kind of see it's kind of like a push-pull kind of thing. So you got to be careful with the sequencing of dosing that. So let's go back and let's revisit. Well, what does it mean if somebody is wet? So they have this congestion. Well, jugular venous distension is a great way to do it. So if you have JVD, remember that's an indication of a right-sided failure, which the most common cause of right-sided failure is the left side failing, right? They may have problems with their breathing, or at least positional breathing. They may have frothy or pink sputum, wheezing, in the absence of history of asthma. So somebody who shouldn't be wheezing, they've never had asthma, never had reactive airway disease, all of a sudden now they're wheezing. That's an indication of congestion or fluid overload. If they have abdominal bloating, weight gain, hepatojugular reflux is positive, they have crackles on auscultation, all of those things are signs that this patient is fluid overloaded and wet. If they are cold or having that low perfusion, that low cardiac output, it could be hypotension, so systolic blood pressure less than 90. The extremities are going to be cold to touch because you're not perfusing the distal parts of circulation, right? So their hands are going to be cold. Granted, it's supposed to be like 39 degrees, 37 degrees on Monday as a low. So when you wake up, come to work, it's supposed to be 37 degrees. You can't say they come out of the cold and then touch their hands and say, oh, they're cold. Give them time to warm up in that case. But if it's hot, but their extremities are cold, then that's an indication of poor perfusion. If they start having confusion because they're not perfusing the brain appropriately, that's an indication of poor perfusion as well. So what are we going to do? So hopefully we're going to catch them in the yellow, and we're going to have them take their diuretics. Loop diuretics, furosemide, is one of the best ones to give them because it works great even at reduced kidney function levels. It can still work well. And it's called Lasix because it lasts 6 hours. So that's why it's called Lasix. There are some thiazide and thiazide-like diuretics that you can also add to the loop diuretic to help with further diuresis. But the key thing is this may improve their symptoms and it may improve their immediate condition, but ultimately these do not carry a mortality benefit at all. Now you have a patient who has poor perfusion, so one of the things we talked about is you have to give them an ionotrope to improve the contractility of the heart. So what do we have at our disposal to do this? Well, we have dobutamine, which is one of the more common ones that we use, but we also have milrinone as well to help us with this. And there's some advantages and disadvantages for each, but either one of these will help improve that contractility and improve the cardiac output. The only thing, one caveat would be if patients on a beta blocker, then maybe milrinone is a better agent than dobutamine to give them in the acute decompensated state. So let's just quick revisit. So if I have warm and wet, so I'm perfusing but I'm congested, the treatments are diuretics and vasodilators. If I am cold and dry, so I'm not perfusing but I'm not congested, then I'm going to give my inotropes, the dobutamine and milrinone, and then I'm going to try to give them a vasodilator, but being careful of what happens to their blood pressure. Okay. If I am cold and wet, so this is the worst of all 4 presentations, then I am going to give a combination because now I have a perfusion problem, but I also have a congestion problem. So I'm going to have to give them diuretics to get rid of all that extra fluid. I'm going to have to give them inotropes to improve that cardiac output, that forward flow. And then when my blood pressure allows me to, I will give a vasodilator as well to further reduce that afterload, further reduce that excessive preload to improve cardiac output. But let's say my patient is either not responding, their condition is just so bad that medications can't work fast enough to get rid of it. I can't get them on that vasodilator because their blood pressure is too low. What else can I do to help them and save their life? One of them is doing hemodialysis. The indications for hemodialysis is AEIOU, where the O is overload, fluid overload. Okay? So hemodialysis, there is an indication in a patient with acute decompensated heart failure whose volume overloaded to manage and treat this because it will pull off all that extra fluid and then restore that cardiac output. You can also then do things to help with cardiac output by doing mechanical circulatory support devices to include an intra-aortic balloon pump, which just helps with that forward flow. But you can imagine invasive, risky. This is last-ditch efforts, right? Ultimately, they could do like a left ventricular assist device or the LVAD, but this patient may ultimately need a heart transplant, which again is not something that's going to happen overnight. It's going to potentially be months to years before they are matched with a heart. So what makes somebody high risk that maybe we need to consider recommending palliative care or hospice care for this patient? Well, one, age. So if they're greater than 70 years of age, doesn't matter what I do, they already have a diseased heart that's elderly, tends to a worse outcome. They can't really tolerate additional insults like that. And if I had a patient who was going through this and they were 30, right? If they have other organ disease, and now they have a cardiovascular disease problem, it's probably not a great prognosis. I already have liver failure, or I have renal failure from my diabetes or whatever, and now they're having heart failure. The systems, the organs that you need to be functioning to be able to help respond to the treatments and to recover from this insult aren't there to help you. So that portends to a worse outcome as well. So if they have another organ system that's failing, those folks tend to have worse outcomes. That maybe the best thing we can do for them is to make them comfortable in their last few days. That is a reasonable treatment option. It's not giving up on the patient, but unfortunately it's reality. We're all going to die sometime, right? Maybe this is this person versus us having to continue to be brutal with our treatments without the hope of a recovery. Because does that patient want to stay in the hospital for the rest of their life? Or do they want to go home? Do they want to be with their grandkids and their kids and stuff like that, right? So maybe we're not going to have that meaningful recovery to make all of this worth the pain and the suffering they're going to go through. Or pain and suffering for the family to go through. So palliative care, hospice care exists for a reason, to make people comfortable in their last few days, few months, depending on what it is. Questions? I know it's a solemn end to this lecture. Okay.
Ended on a high.
All right. Well, I am